Welcome, everyone. Thank you so much for being here for this Dean's Lecture in partnership with the Yale School of Medicine's program on aging. Please note that this event is being recorded. I would now like to introduce Dr. Megan Ranney, Dean of the Yale School of Public Health, to officially open our event.
Thank you, Holly, and it's lovely to see you all here. I'm really grateful for the opportunity to welcome you to this tremendous event. So today's lecture, entitled Positioning Dementia Care Science Towards Effective Implementation, is one that I'm sure that we can all connect to, as all of us have loved ones who are either growing older or who we miss. We know that dementia, Alzheimer's dementia, and related dementia disorders affect every one of us differently, whether memory, thinking, or behavior. And we know that although it affects many adults as we age, it is something that is a persistent struggle. It's not predictable, caregiving supports are insufficient, and certainly the way that our medical system is set up does not fully support us. With that, I'm tremendously excited to welcome Dr. Gaugler and also to turn the stage over to Dr. Gill, because here at the School of Public Health, in partnership with the School of Medicine, we know that translation is key. The work that we do scientifically matters, but the work that we do to translate our science out into the real world, to make lives better, to help people age gracefully, to preserve both their physical, but also their social, emotional, and economic well-being is perhaps the most important thing that we can do. And knowing Dr. Gaugler, I know that we are going to learn a lot about how to do that today. So I would now like to hand the microphone to Dr. Thomas Gill, Professor of Medicine, Epi of Chronic Disease and Investigative Medicine, and Director of the Yale Program on Aging, who will officially introduce Dr. Gaugler. And I would just be remiss to end this without saying how grateful I am for the partnership with the Yale Program on Aging, how much you have done over the last decades to really create and nurture this partnership, and how committed we are to continuing to grow it and to support work on aging here at the Med School and School of Public Health, but also across the university. Thank you.
Thank you, Megan. Gives me great pleasure to introduce Dr. Joseph Gaugler as the 2024 Yale Visiting Professor in Aging and Dean's Lecturer. Dr. Gaugler is the Robert L. Kane Endowed Chair in Long-Term Care in Aging and Distinguished University McKnight Professor at the University of Minnesota School of Public Health, where he also serves as the Director for the Center of Healthy Aging and Innovation and the Public Health Center of Excellence on Dementia Caregiving. Dr. Gaugler received his bachelor's degree in psychology from Gustavus Adolphus College in St. Peter, Minnesota, and his master's and doctoral degrees in human development and family studies from Penn State University. Subsequently, he was a postdoctoral fellow at the University of Minnesota, where he worked under the tutelage of Robert and Rosalie Kane. Upon completion of his postdoctoral training, Dr. Gaugler landed his first faculty position at the University of Kentucky College of Medicine in the Department of Behavioral Science. After 5 years, he was recruited back to the University of Minnesota as faculty member of the School of Nursing, where he rose through the ranks to long-term care professor of nursing in 2016. A few years later, he assumed his current distinguished faculty position. Dr. Gaugler's research examines the sources and effectiveness of long-term care for people living with Alzheimer's disease and other chronic conditions. As an applied gerontologist, his interests include Alzheimer's disease and long-term care, the longitudinal ramifications of family care for people living with dementia and other chronic conditions, and the effectiveness of community-based and psychosocial services for older persons living with dementia and their caregiving families. Dr. Gaugler was associate core leader of the implementation core for the NIA-sponsored Impact Collaboratory and is currently editor-in-chief for The Gerontologist, one of the preeminent scientific journals in the field. Dr. Gaugler's research has been funded by the National Institute on Aging, the Department of Defense, and the CDC. He is currently recipient of an NIA Academic Leadership Career Award. We are delighted and honored that Dr. Gaugler is able to talk with us this afternoon, both in person and via Zoom. The title of his presentation is shown here, is Positioning Dementia Care Science Towards Effective Implementation. Welcome, Joe. Yeah, I'll pick that off.
Thanks so much. That's very kind. Appreciate it. Well, thank you so much, Dr. Gill, Dean Ramey, everyone here at Yale. I can't tell you what an honor it is to be here and how humbling it is to be here. I certainly am aware of some of the names of the distinguished scholars who preceded me as the Yale visiting professor on aging. So again, I'm just so thrilled to be here, to be talking with so many great colleagues who I've partnered with over the years, but then also hopefully talking with new colleagues and learning more about all of the wonderful work you do here at Yale. And it always serves as a model to many of us across the country, certainly at the University of Minnesota. And I hope some of the ideas and thoughts that I'm sharing with you today resonate with a lot of the great work you're doing here. Okay, hopefully this goes here. Wonderful. So I wanted to start with some acknowledgments here. Certainly my research team, which is called the Families and Long-Term Care Projects team, a number of wonderful individuals who have made all of this work possible. You see some of the grants that I'll be alluding to here on this particular slide. One that actually has, I think, advanced some of my thinking in this space is our newly funded AD/ADRD Roybal Center. It's called Embrace. I so apologize for the acronyms, everybody, but this is called Establishing Mechanisms of Benefit to Reinforce the Alzheimer's Care Experience. I actually don't think it's bad. I came up with that myself. So, I mean, at least you can remember that. And some of the other work, including the Academic Career Award, Dr. Gill mentioned, and some of these other particular grants as well. So what are we going to talk about today? Really briefly, as best as I can, and this could really be the subject of an entire presentation. Where are we at in terms of the science of dementia care? And when I say dementia care here, I'm really talking about the care for people living with dementia. It has been an area of focus, transdisciplinary focus in gerontology and geriatrics, probably for at least 40 to 50 years. And so where has the science progressed to? And that really leads to the crux of the talk, which is the science of dementia care ready to be scaled, disseminated, and implemented? And if so, what can we do to facilitate that work? I think for many of you here, certainly for me, when I think of implementation, yes, I think of it as a scholarly pursuit, but in some ways, I think of it as an ethical imperative. I'm sure many of you are familiar with the oft-cited statistic. Generally, it takes 17 to 20 years from basic discovery to effective implementation of an evidence-based intervention across biomedical disciplines. And that only happens for maybe 14% of those innovations. If we think about the amount of money that has been spent, the amount of time that has been spent, not only on the part of researchers, but more importantly, participants, how is that efficient? How is that appropriate? So again, for those of us in this space of implementation, it in some ways is not only scholarly, I would argue at some levels it's a calling. But with that in mind, what can we do scientifically to facilitate implementation? Perhaps dementia care is similar to other fields or areas you're involved in where maybe the science has progressed to some point, but how much of the innovation is actually reaching the people it was meant to benefit? Certainly in dementia, I would argue not as many as we would like. Can we do something scientifically to expedite and facilitate that? That's really some of these areas I wanted to focus on in the latter part of the talk. And then really to wrap it up with thinking about this from a public health lens and perspective. Why are we doing all this anyway? Why are we doing this dementia care science? Why do we care about implementation? And I think a strong argument behind that is the fact that dementia caregiving is a public health priority. Maybe it's not always recognized as such, identified as such. It may not even be recognized or identified as such in your own curricula or maybe in your own research, but nonetheless, I would argue it is. And it's high time that public health started paying attention to it as such. So let's kind of take us through the last 60 years or so of caregiving science. This is by no means complete, but it was my attempt to more or less provide an overview of how did the science of caregiving, specifically dementia care, develop over time. It really began in the 60s of identifying caregiving as an issue that was occurring amongst older and aging samples and participants. And that really led through the late 70s into the 80s of measurement. What are some of the key concepts of caregiving? This led to the development, for example, of caregiving burden as a measure and concept. And then as the 80s progressed into the early 90s, there was then a focus on theory, conceptualization of caregiving, the caregiving stress process by Dr. Leonard Perlin. A major figure in this space, in addition to Dr. Steve Zaret, was also Dr. Richard Schultz, who from the 90s and beyond really helmed a series of critical studies, first on the longitudinal ramifications of caregiving and dementia caregiving, the identification of key transitions in dementia caregiving, and then finally into intervention design, more rigorous, in many cases, multi-component interventions designed to alleviate caregiving stress, caregiving depression, and other types of adverse outcomes related to caregiving. And along with that, by the early 2000s, the literature emerged sufficiently where you started to see systematic reviews and meta-analyses beginning to emerge, identifying what were some of the key risk factors to adverse dementia caregiving outcomes, what were some of the characteristics that seemed associated with more adverse outcomes in caregiving, et cetera. Then finally, over the last 20 years or so, there's been greater attention to equity and disparities in caregiving and some of these complexities. Peggy Dilworth Anderson at University of North Carolina, Chapel Hill has authored seminal work in this area, beginning with this very important 2002 review. Meta-analyses began to emerge of caregiving interventions, finally leading to an understanding that it is time for us to try to build on this body of research to get it into the public, whether it's through healthcare systems, community organizations, or other types of means. And importantly, alongside that, there have been a number of key efforts and milestones, really beginning, I would argue, in 2011 with the National Alzheimer's Project Act, where there has been a pretty thorough reconsideration of the state of dementia care science. How can we advance the science of dementia care, given this roughly 40 to 50 years of empirical and qualitative and other types of work to date? So this table came out of a book that I had edited in 2021 called Bridging the Family Care Gap. And the whole point of the book was really to try to understand, is family caregiving sustainable as we know it? We rely, in terms of the long-term care of the US, on a vast, largely unpaid network of family members, friends, and others to provide, and more often than not, chronic care to older adults over time. And with this in mind, can we actually rely on families to continue doing this? There have been some suggestions from the ARP and others. I don't know if it's really been scientifically validated necessarily, but that in the upcoming decades, due to a number of sociodemographic trends, for example, decreases in birth rate, other types of trends, that the number of available family members or other unpaid individuals to provide care to older adults in need is going to drop significantly. Right now, that care ratio is maybe 7 to 1 or so. Within the next 30 years, that could drop to 4 to 1. What can offset that potential impending care gap? Okay. So one of the recommendations that came up consistently in many of these summits, many of these key reports that were starting to emerge over the past 10 years, was the need to advance and apply implementation science and dissemination research to the field of caregiving. You see in the columns here at the time, and this again was 2021 or so, major reports came out from the National Academies of Science, Engineering, and Medicine. The left-hand column, ASPE, actually refers to the 2017 first of its kind Summit in Dementia Care Services and Supports, where many of those of us interested in dementia care finally came together for the first time to really take stock of the field and to lay out an agenda for the National Institutes of Health and others to pursue to advance the science of dementia care, which to date has really led to a number of major infrastructural investments on the part of NIA. But certainly a key theme across these different initiatives has been implementation. And to quickly take us through, I'm not going to belabor all of these points on these couple slides. There was another summit held in 2020. Again, what was one of the main recommendations? You see it underlined here: develop scalable, sustainable, and actionable interventions, dementia and dementia care interventions that payers and providers can use off the shelf in practice. I put a question mark after this. Does anyone know of any intervention that's been developed that's truly off the shelf? Just out of curiosity. I don't think I know of one. I'm sure they're out there and maybe I'm unaware. In dementia care, I don't really. Maybe like nudges or something, that type of work. But honestly, I mean, and that's an important point to remember when we think of implementation science. I mean, I would argue a key aspect of implementation science as a methodology that it contributes is understanding how to adapt interventions to fit them to diverse contexts and to do so in a rigorous fashion. Too often than not, that adaptation process, even though it's often inevitable, when you take a intervention that's published as a randomized controlled trial in a journal and try to disseminate or implement it in some type of organization, that organization is going to want to change the intervention. It's almost unavoidable. How do you do that in a way that still maintains the essential function of the intervention? And that to me is a key point in this whole question of, is the science of dementia care ready to actually be readily implemented and disseminated? And perhaps it's in other areas as well. Finally, another great conference that was held by Catherine Riffin and her colleagues at Cornell. Implementation science came up over and over again as a need to advance dementia care science. And you can see some of the specific recommendations and implementation here. Developing a unified strategy for advancing the science in this space. What are best practices for scaling and expanding the reach of evidence-based interventions in dementia care? What are some of the strategies for monitoring fidelity in the real world? And then finally, you can see some other recommendations as well. So, I mean, the take-home point to all of this is it keeps coming up over and over again. All these national conferences, all these national reports. We need to implement the interventions we develop. We need to disseminate that successfully. But many of those recommendations stop there as to, well, how can implementation science actually help us? So in this next part of the talk, I wanted to pivot a little bit more, at least to how I envision this. I'd mentioned to you earlier how being at Yale is humbling. And of course, in the meeting before this, I didn't realize you actually have a center. I'm going to try the acronym, folks. What is it? CISMIPS or something? Center for Implementation Science Methods in what? Public Prevention Science. Okay, thank you. CISMIPS. So clearly you're doing really advanced work in a lot of these ways analytically in implementation science. And so maybe my approach here is simplistic, but nonetheless, I still think it's important when framing where this field needs to go. We know that moving evidence to a care setting is complex. I realize you've had Dr. Gitlin here, a very close colleague of mine, giving this presentation several years ago. And this is something she and I have talked about a great deal in our roles in the Impact Collaboratory at NIA. And if those of you that don't know what the Impact Collaboratory is, very significant investment on NIA to really figure out how to embed dementia care innovations into healthcare settings. And so we were both involved in leading the implementation core. So we had to do a lot of thinking about how does this apply to the dementia care space. And certainly often trying to take evidence that was developed, particularly in, say, the traditional randomized controlled trial methodology and format, and then trying to get it to a healthcare or other setting is often like putting a square peg into a round hole. There are often elements of that intervention that aren't scalable, they don't fit at all, whether it's in terms of who the interventionist is and who can deliver the intervention, whether it's to how complex the protocol is to actually deliver the intervention. Forgive me my side stories, but I once remember I was at a conference and there was a colleague of mine, someone I knew really well. I very much respect their work, but they were talking about a technology intervention and they were talking about scaling it and implementing it. And they had mentioned, well, our training manual is 120 pages long. And when you think about that from common sense, not from a scholarly, from common sense, how could you take a 120-page training manual, go to a healthcare or community organization, say, implement this? Could you? You're from Yale. Yes, no, no. So again, I mean, it's these types of complications, these gaps in the translational continuum that keep coming up over and over again, but are necessary to address and think about perhaps much earlier in the dissemination or in the translational intervention design process. Again, this is a very, very quick and dirty overview of implementation science and how I think about it. But at least I think it frames this discussion. And a light bulb moment for me, when I was asked or tasked to be part of the implementation core at NIA Impact, I had done some work in implementation, but I certainly was by no means an expert or really knew a whole lot about implementation science as a methodology. And so maybe this will come as a strategy or tip for you. Maybe I shouldn't admit this. So I felt, well, if I need to learn about implementation science, what I'll do is I'll create a doctoral dissertation course and teach it. So I taught the course, an interdisciplinary doctoral seminar. It went really well in 2020. And one of the light bulb moments for me when I first started reading about implementation is when I first thought of implementation, I still had in my mind, in order for implementation to be successful, one must focus on healthcare outcomes tested in that original intervention. And caregiving could be caregiving stress, the health of older participants, et cetera. But the reality is implementation, at least in its purest sense, is really number one about determining whether implementation strategies that you take to better embed or integrate an innovation lead to implementation outcomes. And implementation outcomes are not the outcomes we often consider as part of, say, earlier stage intervention testing, but really are things like feasibility, appropriateness, degree of penetration into routine workflow, fidelity, at least in terms of can the organization I'm working with deliver the intervention as intended. So a different set of outcomes, and really in this case, a different independent variable, wouldn't you say? The independent variable isn't whether someone gets an intervention or not. The independent variable is really testing one or more strategies to see if it leads to successful adoption and implementation of a given intervention. So it's a different way of thinking about what you're actually studying when trying to determine, did I implement my intervention successfully or not? Okay. So when we think of it this way, what are some of the considerations that we must realize when implementing complex interventions, certainly dementia care interventions, successfully? And you can see some examples here. When we think of the various care settings that certainly are relevant for people living with dementia, they're very different and heterogeneous. And within each of those care settings, they probably have varying levels of tolerance in terms of what kind of complex interventions can actually be implemented in those settings. Does the intervention align with existing workflow? Is the staff and others actually ready to implement? I'll give you a good example of this. And again, unfortunately, I seem to learn by making lots of mistakes, and this is a good one. We did a national trial of what's called Adult Day Services. For those of you not familiar, Adult Day Services community-based program that provides respite and relief to caregivers and also provides some therapeutic benefits and activities for older people who attend them for varying hours a day, varying number of days a week. So this was actually the ADS Plus project. So what we were doing was we embedded an evidence-based dementia care intervention into adult day programs. It was a cluster randomized design, a national trial. I think we included 40 to 50 adult day programs, half of them randomly assigned to deliver ADS Plus, which was this kind of augmentation dementia care intervention program. One of the problems we had is we got a bunch of letters of support when we put the proposal in. All of the directors wanted to do it. So we might have collected 80 letters of support, way more than we needed for the intervention. We get funded. We go back and reach out to those directors. What do you think happened? What do you think that some of the directors said? Oh, well, I mean, this is too much. We can't handle this. We didn't expect it to be this much. Hung up. So we lost maybe 20 to 30 programs just from the letters of support only. Now, at the time, I always thought, well, boy, if the director signs on, they're obviously going to be on board. The reality is we had no understanding of the true organizational readiness of these programs before we started. Had I known that, had I utilized that, again, a key implementation science tenet, we may have avoided a lot of that and had a much more smoother onboarding of programs into that program, into that intervention. Okay. It's a good example there of how implementation science can really help us in some of these more complex later stage intervention designs. You see a number of other considerations here. Sometimes de-implementation is as important as implementation. Is an organization, basically delivering a service that we know needs to be de-implemented in order to facilitate adoption of a new innovation? And what does that look like? So again, these are all contextual, complex considerations that are necessary often for successfully testing. I would argue interventions, even if not at an efficacy, at a real world efficacy stage or beyond. So how does actually understanding implementation science as a method help us in all of this? How does it help us navigate this very complex set of considerations in terms of setting and all these other challenges that many of our partner organizations might have? I would argue there are 4 areas it can help with. The first are strategies. The second are theories, models, and frameworks. Third are outcomes, and you heard me allude to some of these already. And then finally, this guidance on adaptation. And so let's talk a little bit about each of these. The first is implementation science has identified a number of strategies that are named, are measurable, can be operationalized, and can be utilized and referred to when actually describing your implementation activity. Again, think of it as a corollary to the independent variable in a traditional intervention. In an implementation trial, the implementation strategy or combination of strategies is the IV. Now, one of the challenges, as with many emerging methodologies, is, and this was as of 2017, there were over 75 or 73 individual implementation strategies identified. So there are many, many to choose from. So what Kirchner did through this ERIC initiative was essentially identified the main categories of implementation strategies to consider. Within each of these categories, there are a number of specific strategies to consider, but you can see some of them here. For example, developing interrelationships with different providers, stakeholders. It's a term that is, not in vogue anymore, but developing interrelationships with the key individuals in an organization who either receive or deliver your intervention. That is one potential strategy. Training and education of those who might be delivering or receiving your intervention. That's another one. And you can see a whole bunch of others as well here. But again, ideally in implementation science, the strategy must be well described, named, identified, and then potentially measured as well. Some of the additional strategies, and again, we considered many of these, first and foremost in our ADS Plus trial, but have been done across a number of dementia care interventions. You can see providing follow-up coaching opportunities to reinforce use of evidence and troubleshoot. We have found this to be very, very effective when delivering dementia care innovation, say with community-based organizations like adult day programs. There often is a need for ongoing coaching, ongoing support to ensure adoption is occurring, and then to identify any barriers. Embed documentation of implementation in the existing workflow, which is easier said than done, I think, as many of us realize, but nonetheless, this again helps to mimic more real-world conditions when we're evaluating our implementation efforts. Integrating staff training, coaching, and fidelity monitoring within existing workflows. I think the one goal we all try to achieve, and it's much easier said than done, depending on the context, is the more we can craft, either whether it's an implementation trial or an effectiveness trial, the more we can craft real-world conditions in the trial, meaning it is not a highly specialized interventionist delivering the intervention. It's the staff we're partnering with itself. The data that we collect in terms of outcomes doesn't have to be collected vis-a-vis the investigator team. It's collected within the healthcare organization. The more we can embed the intervention within the existing workflow and training, again, the more we can mimic the real world condition, the more likely it is then that we can ascertain whether our intervention, one, is adopted and implemented effectively, and whether it's done so with success. You've already heard me talk about organizational readiness for change, but again, implementation science has developed specific measures of organizational readiness that, again, had I known that these had existed prior to the ADS Plus study, I could have administered these to determine these programs that submit letters of support. Are they actually ready? And then thinking of it from a more complex perspective, you probably have to go beyond whoever's in charge to understand organizational readiness, wouldn't you? Like the staff themselves, are they ready to do this? Or whomever you're going to task to actually be trained and deliver the intervention. That can be measured and should be. So another aspect of implementation science is its contribution in the space of theories, models, and frameworks. And this is from a very helpful book in implementation science called The Handbook of Implementation Science by Per Nilsson from 2020. And again, we don't need to go through this in depth at all, but what implementation science also gives us through its theories, models, and frameworks is a way to, number one, identify those potential influences to successful implementation, barriers, facilitators. It also helps us describe or guide the process of translation of research into practice, and then finally evaluating implementation. So those of you familiar with implementation science, there are probably many models that you're familiar with that fit in this category. For example, a determinant framework that's very popular in implementation science is what's called CFIR, the Consolidated Framework of Implementation Research. Many of you might be familiar with that. It does a very expansive job, including with validated measures that identify all of these different potential barriers and facilitators to implementation. Theories, particularly implementation theories, they're slightly different from determinant frameworks in that not only do they identify barriers and facilitators, but theories provide insights as to why implementation might be successful. One example is normalization process theory. That's often an implementation theory that's used, but there are classic theories in our disciplines that can be applied too. In terms of evaluation frameworks, I'm sure many of you have heard of REAIM. I mean, that's essentially an evaluation framework. Note that REAIM does not tell us anything about barriers or facilitators to implementation, nor about why implementation is effective. But it does offer a very easy to know and understand heuristic for what should be evaluated in terms of outcomes, okay? Then process models really get into how do you do the implementation? How do you do the translation? So again, just like with strategies, there are an overwhelming number of theories, models, and frameworks to pick from. Many frameworks. But again, this is what's something that is helpful if we're planning to propose any type of implementation work, is to be familiar with these so it can help frame our work, frame our measurement and analyses. And then finally, what implementation science gives us are measures to evaluate success. Many of these validated. They can be empirical, sometimes they're qualitative too, but nonetheless, these are the types of measures to consider when determining whether implementation actually worked in our given example. Acceptability and appropriateness. So acceptability is the perceptions among key individuals that an intervention is actually agreeable or satisfied with it, all the way down to fidelity. Again, I think many of us are familiar with that construct. Was the intervention implemented as it was prescribed? Key measure of implementation success. Feasibility is important too, which is the extent to which a program or policy can actually be used or carried out in a given organization. Again, these are all key outcomes. I think it's worthwhile for us to ask ourselves, how often are we considering these measures when we're actually designing and testing an intervention? Often when I ask these questions, sometimes it's a critique of my own work that I'm not doing it enough. Actually, it is a critique. I know many of the earlier interventions I developed, I often never really paid much attention to scalability, didn't really pay much attention to things like feasibility per se. I was focused more on, was it efficacious? And in a way, I think I was very similar to much of the overall biomedical science literature. Are many of us actually incentivized to create interventions that are scalable at all? Or are we incentivized, at least those of us in research, are we incentivized to simply conduct a randomized controlled trial with a statistically significant effect that gets published and goes nowhere else? I think the latter is where we're incentivized. But is that, again, is that when we think of implementation as an ethical imperative, is that the way it should be? And I would argue it's not. Unfortunately, it took me a while to come around. Hopefully it doesn't take all of you as long. This is a frightening slide. And so I'm not going to go through this very much, but this gives you a sense of a big emphasis in implementation is adaptation. I'm sure many of you are familiar, for example, with cultural adaptation. How do we culturally adapt an intervention? So again, it aligns and fits with the values, preferences, and needs of given communities, diverse communities. But quite frankly, adaptation is necessary across all range of contexts. This is called the frame. And this is almost more useful, if not as like a code book, as a tool that one can understand when categorizing the often inevitable types of adaptations that occur when you're taking an intervention and then working with the community organization to put it out into the field. Again, there's no need to go through this in depth, but the key, why I think this is such an important consideration and contribution to how we do dementia care science and intervention work is it gives us a much more structured way to document what was changed and why. Again, think about the incentivization I told you about in terms of how we do our science. Am I incentivized to tell a peer reviewer or journal editor that I changed intervention X, Y, and Z this way, but look, I still have great outcomes? You would hope you would do that, but I have a feeling many changes are made and they're not documented at all. But think about this from the standpoint of implementation. If you are trying to implement an intervention and you don't document how and why a change was made, if one tries to then take that intervention and bring it to another context, it becomes a series of ad hoc changes that may really influence whether the intervention still has true benefit to the people it's meant to benefit. Does that all make sense? I hope it does. Before I transition to the last part of the talk, I just want to, hopefully if you all can get these slides, we created a resource for the investigators of the NI Impact Collaboratory that, again, tried to distill some of these points in a real easy to understand format. But again, it more or less aligns with what I just told you. where can I find more resources about picking the right implementation theory, model, or framework? You can click on these links. What are the strategies to lead to successful implementation? We found some really good resources online to do that, as well as a great presentation from the NI Impact Collaboratory. Similarly, with measures, there are 3 actual measures that have been validated on acceptability, feasibility, and appropriateness that can also be used and even potentially modified for your own trials or others' trials if you're interested. Dr. Enola Proctor is kind of the guru of implementation measurement, and she also gave a great impact grand rounds for us. And then finally, if you wish to, well, Halloween is coming up. If you wish to scare yourself, you can always look at Frame too. So I'll give you that link as well. Okay, so when we consider this from a design standpoint and perspective, and again, I do not have the insights maybe some of you have from an analytics standpoint, particularly given this very exciting center that I learned more about. But in terms of what I think, what can we do in terms of our designs to make them more ready to be implemented? And I really thought of these. Now, of course, after some of the conversations with you, this could be expanded a bit, and maybe I'll talk a little bit about that too. But the first is this idea of the need for robust, inclusive, and multi-level engagement from not only leadership that we might be working with, but also those staff and others that are likely the people we're going to be asking to potentially deliver an intervention, to understand as early as possible, is what we're doing feasible? For example, if I decide to propose a multi-component intervention, is component A, is its intensity and duration appropriate to you from your perspective? Is this too costly to provide? If you can provide this for a cost of X amount of dollars, would you do it? Those kinds of conversations, again, highly qualitative, but nonetheless are really critical when trying to consider what should our intervention consist of. And if we do propose multi-component interventions, how should the components be quote unquote bounded? Okay, bounded based on the perspectives of those who are most likely to either benefit or deliver the intervention in the long run. The second, and I'm a big believer in this, is the need to understand mixed methods and to incorporate this. I think for a lot of this work, I would argue throughout non-pharmacological interventions or behavioral intervention design, and again, this may prove popular to some of you, for some of you it may not, I really strongly believe in the need for qualitative methods embedded with quantitative ones. I can just reflect on my own work, how much that has added from the perspective of understanding, for example, key mediators or moderators that a priori we didn't identify, but that could be valuable to understand whether and for whom an intervention works, number one. Mixed methods also, I think, are incredibly helpful when considering, are there ways where we can simultaneously determine not only the effectiveness of an intervention in a traditional way, but we can also use, for example, qualitative data to collect key information on implementation relevant measures that can give us some insights as to not only is the intervention effective, but is it appropriate? Is it feasible? Can it be scalable? And doing that concurrently, I think, is a powerful way to maybe push our interventions a little bit more quickly along the translational continuum versus the standard traditional randomized control trial, all quantitative, okay? Then there are some other ideas here, which we're going to talk a little bit here in depth. You've heard me allude to concurrently collecting implementation and effectiveness data simultaneously. This is actually what are called hybrid effectiveness studies. Karan, who is a very well-known implementation science working out of the VA, developed kind of a 3-level model of hybrid effectiveness designs that I've been very excited about when considering my own interventions, even at the earliest stages of intervention design. This idea of the this methodology of the multi-optimization strategy, some of you may be familiar with this, basically applying engineering principles to multi-component interventions at the beginning of intervention design, so one can understand which combination of components are most likely to lead to positive outcomes. How do we often do multi-component interventions? Generally, we'll identify what we think are components that will be effective. We deliver them all, and hopefully they show an effect. But oftentimes when one takes a multi-component intervention, 3, 4, 5 components, to a partner organization to deploy, they might not be able to do all the components. They may not feel all the components are valuable or appropriate. Is there a way to optimize our multi-component designs in such a way that when we actually get to that point of implementation, do we have a optimized intervention that includes those components that are most essential that are driving benefit. I realize this is a quick and dirty overview of most, but nonetheless, I mean, it's very appealing to me, this idea of engineering interventions. And I learned from Dr. Tong and Dr. Chen at the conversation right before this presentation, apparently there's yet another acronym called LARGO, which is another way of applying engineering principles that SysMIPS is doing. I'm actually going to read more up on that myself. The last aspect here, where how do I feel we can advance and make the translational continuum more effective and efficient, is this idea of better testing mechanisms of benefit of our interventions. How many of us really truly know why our intervention works? Again, we might know whether it works. We did a randomized control trial, again, and people who are randomly assigned to the treatment condition showed benefit versus those in usual care control or something. But in the end, do you really know why the intervention drove benefit? And why does this matter for the context, the discussion of implementation? I would argue, if you know why an intervention works, that when you reach that inevitable point of adaptation, when you make those changes, you will know what you can change versus what you shouldn't change. And too often we don't know that. And so when interventions are adapted, we have no understanding as to, are we changing things that really are adversely influencing the essential aspects of the intervention? And I don't think many of us can really answer that question well. I know I can't for many of my interventions. Maybe you can, but I can't. And I see this as something that's really been an impediment to, again, successful dissemination and implementation of dementia care work. This is an example here, going back to some of the design strategies of the hybrid effectiveness studies I had talked about. You can see they're arranged on a 3-point continuum. Hybrid type 1 studies, the primary aim is determining effectiveness of a clinical intervention. But a secondary aim is to understand implementation barriers and facilitators. So using ADS Plus as an example I talked to you about, that actually was a hybrid type 1 study. Again, the main goal was determining whether ADS Plus was effective for caregivers as well as persons with dementia who were using adult day services and were randomly assigned to the ADS Plus condition. And this is where mixed methods became very powerful. We collected and embedded a number of qualitative data elements through open-ended items, through interviews of staff and caregivers to kind of get a sense of how was the ADS Plus implemented? What were some of the issues and challenges to doing it? Those kinds of things. And so it ended up being very powerful. And we were able to disseminate some important work in this space, really showing the implementation context of ADS Plus alongside what ended up being an effective intervention. Why does all this matter? It matters because one day we might want to get ADS Plus out nationally. And if we have this understanding of the implementation process, we're going to have a much better sense of how should we package this, how should we scale this, and finally, how should it be actually deployed and disseminated to adult day programs across the US. Okay. Then moving on to hybrid type 2 and hybrid type 3. Hybrid type 2 is actual simultaneous testing of an effectiveness of an intervention, as well as the effectiveness really of an implementation strategy. So doing those simultaneously. And then finally to hybrid type 3, these are implementation trials. So in this case, the implementation strategy and its effects on implementation outcomes are the most important prioritized aspect of the study. The secondary aim is then looking at outcomes of benefit for the participants themselves. Out of curiosity, which one of these do you think would be the hardest to conduct? Which one? 2 would be the hardest. I mean, try to think through, how would you conduct and design a study where you're simultaneously analyzing the effects of an implementation strategy with the intervention itself? It's not easy. Okay. And many, I know people I've talked to have talked about how challenging it is to do an actual type 2 study. So this just kind of, it gives you some examples of these different types. So you can see as a type 1, randomized trial and cluster designs to examine the clinical outcomes, but then collecting implementation data using qualitative approaches to, again, understand barriers and facilitators. Type 2, so here's an example using a randomized trial and cluster design to examine, again, the clinical outcomes, using theory to guide implementation, and then formally analyzing the implementation aspects of the intervention and incorporating different individual stakeholders or interventionists, usually often relying on a range of different data collection strategies. And then you see type 3 there again, which we've already talked about. So when thinking of conceptualization of interventions, I've always been a big believer in conceptual models. That's not new to me. It might not be new to many of you. But in thinking of this idea of how to better understand mechanisms of action and mechanisms of benefit, and this is an example of a R21, basically an intervention development study we're doing now called Home Alone. This is for people living alone who have cognitive concerns or impairment. And the intervention includes two components. Behavioral activation is one and environmental modification is the other. And what we really tried to do when conducting this study, we did a couple, or conducting the study, we were doing a couple of things. One is we wanted to be clear on what we thought was the hypothesized mechanism of benefit. So theoretically, behavioral activation, we believe, will be directly linked to increasing pleasant and fulfilling activity engagement for people living alone. And by extension, it will then enhance these various outcomes you see on the right. Whereas environmental modification will reduce environmental press and again, will improve these outcomes on the part of participants. We are measuring the mechanisms. And again, our goal is to actually test whether these intervention components together influence these outcomes as we hypothesize. Even though this is a developmental study, it is also a hybrid type 1 effectiveness study. So what we're doing here is while we're collecting this information on the potential effects of the intervention on outcomes, we're collecting a wide range of data, quantitative and qualitative, and implementation too. Because our goal is, even though this is considered stage 1 intervention, if we understand some of these key implementation outcomes, again, we can better scale and craft an intervention while we're even in a randomized controlled trial that will have higher implementation potential. So what are mechanisms? And I'll wrap up my talk here. Mechanisms, again, these are the processes through which an intervention influences a key outcome. In many fields, certainly in dementia care, but even beyond, one example is medication adherence. Many interventions that have been tested and developed don't test their mechanisms. So again, they don't know, at least empirically, why, or even qualitatively, why their intervention works or not. Why this is important is if we understand and test mechanisms, we can identify shared mechanisms of benefit. For example, can different approaches yield similar outcomes? It can clarify essential treatment components, again, to guide and scale implementation, and may even enhance targeting by specifying under which conditions interventions are most effective. Often mechanisms might be influencing multiple symptoms and outcomes. If we can test and measure and identify those mechanisms, again, it can give us a better sense of what is that real essential ingredient that we want to focus on when testing and establishing our intervention as potentially efficacious or effective. A lot of this comes from the experimental medicine methodology, and there's really 3 essential elements to establishing a mechanism. One, an intervention is hypothesized to influence this target, which is the mechanism, the change in process, that results in a positive outcome. These experimental approaches are utilized to ascertain whether an intervention actually influences the mechanism, and then the target itself, the mechanism, can be measured. Okay, so this is what experimental medicine is. You can see a lot of this was derived through biological medicine, the testing of drugs, for example, but was applied now to behavioral intervention. This is not without its problems, but at the very least, it gives us a methodology to think about understanding and testing mechanisms. Here you see an example at the top of the traditional efficacy test, again, largely focusing on intervention and outcome, where this whole idea, some of you may have heard of the science of behavioral change, experimental medicine. The goal really is to determine, one, can we measure a mechanism, sometimes through multiple means? And then finally, does the intervention first and foremost influence that mechanism? And then by extension, does that mechanism influence the outcome as well? So really it's mediational model testing. This is a very simplistic way to talk about it. I realize when you really get into this, how often does a mechanism fully mediate the relationship between an intervention and outcome when you move beyond biological measures? Probably rarely. So there's likely much more complex pathways to test. But nonetheless, it gives us an idea to really understand if a particular mechanism is influenced at various levels in multiple interventions. So getting to the crux of this here, and tying it back to implementation. A big contribution of implementation, and again, I ask myself, do I do this enough, is do we understand the form versus function of an intervention? The core functions, and again, it's very akin to mechanisms, is really about how do the activities and components of an intervention operate to influence outcomes? Very similar to mechanisms, isn't it? If we can identify a function or know what it is, we can be fairly certain this is not something that should be changed if we adapt an intervention. Whereas when you consider forms, these are the activities of the intervention. Who's doing what, when, where, why, and how. A challenge I raise to you, a challenge I raise to myself is how consistently are we mapping forms to core functions? Okay. Thanks, Tom. So tying this all together, the designs, the science, the mechanisms and such, it is core to implementation, I argue. And really at the heart of it is this idea of if we know why our interventions work, we can more successfully implement and apply those many implementation science methodologies I had discussed. To tie this up, why does all of this matter in the big picture? It matters because I believe, and many of us believe, dementia caregiving is indeed a public health priority. It affects the health of the population. There are 11 million people who are providing unpaid care to people living with dementia. If you put a dollar value on this, the annual revenue or the dollar value of dementia caregiving in the US is 9 times that of McDonald's revenue in any given year. It's half of that of Walmart. So obviously our long-term care system relies on this unpaid network, but its effects are unequally borne by members of the population. Women, there are racial and ethnic disparities. Certainly symptomatology of dementia also can really identify those who might struggle as caregiving. There are strategies we know that work, but how can we best implement and employ them? I would argue the whole point of my talk revolves around that. How do we advance our science to do so? I know I went long, I'm sorry, but time's for questions or discussion. Thanks. You have a little bit of time.
I wanted to thank you for that wonderful talk and also being an incredible colleague to many people in this room. And we have this little gift for you. Thank you so much for the talk. And I'd like to open it up for questions from the audience. We have about 6 minutes before the class comes in.
Should have kept going, Tom. That's okay. Yeah.
Okay, can you hear me?
Yes. Thank
Okay.
you.
So if somebody who has no experience with implementation science is interested in starting to bring some of that into their future work, what would be some of your first suggestions for them?
If you get these slides, one of my suggestions would be, whoops, of course I screwed it up. That slide I showed you, that kind of little cheat sheet of key resources for theories, models, and frameworks, strategies, outcomes, and adaptation. I would start there and becoming familiar with that. The other thing I can recommend to you as well is I actually, like I said, I didn't know much about implementation, and if you can't do, teach. So I created an implementation science doctoral seminar. That's online, the syllabus. And if you ever want to have access to that, please follow up with me and I can share that with you too. The syllabus isn't groundbreaking. I think it includes some of the key classic tests and impacts in implementation as well as the readings, but that to me would be a key starting point. There are some summer institutes and others that are offered in implementation science that are really valuable. If you go to Academy Health, for example, they have a very vibrant implementation science section. That might be also a good way to start getting connected into the area and space. So those would be my initial recommendations for you. Yep.
Hi, Professor. Thank you for the lecture today. I would like to consult you 2 questions. First is about my thesis in my undergraduate study. So I participated in a community-based intervention evidence-based intervention program for the elderly stroke patients. Okay. And I actually investigated especially about how the village doctors in the urban China area, they deliver our intervention program to the elderly stroke patients. So we do want to, because this is a 1-year intervention and we want to do the follow-up study after 5 years to this intervention program. I tried to use the REAIM framework to design my qualitative part questionnaires, but I found out that it's hard for me to it's hard for me to avoid leading questions to the village doctors and using the REAIM framework to design my questions. I wonder, do you have any? Because I know that for the quantitative part, maybe we have more lectures to consult, but for the qualitative part, I think it's harder for me to design the questions. My second question is that I am really interested in your research direction. I'm thinking like whether I have chances to participate in your project and engage with.
Well, for the second question, that's an easy answer. Yes. I mean, just reach out. Hopefully my contact information will be shared with you. I'm happy to talk with you about any of the work we're doing anytime. The first question is more interesting in that, and I apologize if I didn't follow it all. You're trying to apply the REAIM framework to those those individuals in the community who are delivering the intervention to better understand, was it successfully implemented and why or why not, correct? And the challenge you had, were they quantitative measures or qualitative? The qualitative, the latter. What I would recommend is REAIM itself is actually fairly empirical. I mean, if you look on the REAIM website, it's pretty clear in terms of how you can measure reach, how you can measure effectiveness, adoption, et cetera. What I would recommend is the outcome measures I shared with you, the implementation outcomes, appropriateness, acceptability, feasibility. Those, on the other hand, I think starting with those constructs, you could craft a number of open-ended items that aren't leading, that actually could give you pretty robust, rich information. I mean, that's been our experience. Well, like when I ask an open-ended question, I don't ask about reach really, I do ask though, tell us about your experience with this program. What about it worked for you? Why? What about it didn't work? Why? If you could redesign this, how would you do this? Would you recommend this to others in a similar situation? Why or why not? Those are the kinds of questions that will elicit richer answers, I would argue. Okay.
All right. I just wanted to comment on that too, because that resonates with some work that I'm doing where you're like asking, did you like this program and things like that? And of course, people want to please you. And so Ashley Hageman, my colleague, has been training us on all these different ways to make that environment more truthful. And there's lots of tips to be able to do that with to get more accurate things for your interventions. But thank you so much for your talk today. And it's been wonderful to get to talk with you in smaller groups. And thanks, everyone.
Thank you so much.